Unmuted.
Next is going to be the roof. Next will be the
Good afternoon, all of us. Welcome to the 59th ECHO session that is going to run for a period of 2 hours. Today, the 12th of April, 2024. We want to welcome the team on ground, but also our online team. Thank you for logging in, and we hope this session is going to be a productive one. So our topic today is approach to a child with pneumonia. We have a group of panelists, very nice experts on board who will be coming in. Our key objectives in approaching a patient with pneumonia, we are going to have an overview of what pneumonia is, its clinical features, the commonest microorganisms that are causing this disease, how we diagnose them, the treatment, and possible complications. So I would like to request the online team to maybe tell me what they expect during the sessions. You can either type in or raise your hand, and we get your expectations during this echo. Things you'd want to be stressed during the session, but also your expectations as we go on with this session. But maybe before we start that, let's have an opening prayer from Dr. Sherina.
Good afternoon, everyone. Let's pray. In the name of the Father, and of the Son, and the Holy Spirit.
Amen.
Heavenly Father, we thank you for our lives. We thank you for the gift of health. Thank you for this day. Thank you for that you blessed us to be here. We continue praying for your mercy and goodness. Father, we pray for this session as we start. May you send your Holy Spirit, send your angels, and may it be a success and may it be a fruitful session. Bless everyone who is in attendance and everyone who has organized this. In this name I prayed and believed. Amen.
Thank you so much, Dr. Sherina. My name, the moderator, is Nadunga Martha. I'm an emergency medicine resident studying in Mbarara University of Science and Technology. I'll be moderating today's session, and I think we can have those comments come in. Thanks for as we text the questions and set the floor to pace, I would like to introduce to you the list of panelists who are going to lead us through this echo session. And I'm going to start with one who is next to me. Please introduce yourself.
Good afternoon once again. I'm called Dr. Nata Sherina. I'm an intern doctor from St. Francis Hospital in Zambia.
Okay, thank you so much. That is going to be our case presenter. We can have another panelist introduce themselves. I can see Dr. Lisa Ryan. You're welcome.
Hi, good afternoon, everyone. My name is Lisa Wren. I am a pediatrician with Seed Global Health and currently working with Rwotomiya University in Mbarara, Uganda.
Okay, thank you so much, Dr. Lisa. She's going to be the pediatrician who will be talking, who will go into detail about the pneumonia. Let's have another panelist. Miss Doreen Katshave.
Are you able to see me?
Yes, we are able to see you.
Good afternoon to you all. My name is Katshave Doreen Kasule. I am a critical care nurse and the current in charge of the neonatal unit at Mbarara Regional Referral Hospital. Yeah, I'm glad to be back as a panelist. Thank you.
Thank you so much, Doreen. She will be taking us through the nursing care of a patient with pneumonia, how the nursing bit would go for a baby with pneumonia. Dr. Doreen, could you please introduce yourself to the panel? Okay, so Dr. Doreen will be joining us shortly, and she's an emergency physician working with Mbarara University, and she will be responsible for the Q&A session. So most of the questions in the chat, she'll be helping out on answering that. So now that we know the group of panelists who are going to be leading us in the session, let's get those responses and we'll see. Okay, I'm seeing some of the questions coming in. So we are going to try to move this a little bit hand in hand. So as you list down for me your expectations, kindly fill in the pretest and we see how it's going to go. It will help us to see whether we are learning anything from the session. Any contributions are welcome. Any expectations, you can please type them in the chat. Okay, one of the participants, Wilfred Andama, wants to know how to make a CPAP manually. I think one of the panelists will answer that in the management. Someone wants to know, is Flucamox indicated in the management of severe pneumonia in the neonates? We shall also have, I think, a session on the management. That will be Dr. Lisa Ryan, who will be answering some of these questions. Complications of pneumonia and their management. What blood investigations are carried out or are important in this case? That will be clearly elaborated during the session. Is oral zinc important in pneumonia management? This is a very interesting question because I think we're using it in managing COVID, but our team of experts will clarify on this. We can have some members maybe raise their hands if you want to. You could also feel better hearing some of those voices.
Hello, good afternoon.
Good afternoon to you.
I'm from Toronto.
Yes, please.
My concern is there is this cough you get in a child. It is dry cough, more marked in the morning and in the evening. So you are not sure whether it is bacterial or viral. How best can it be managed?
Very good question, very interesting. We shall have a good elaboration of how the pneumonias are handled, how you approach the cough in the morning and in the afternoon, evenings, and their associated
Hello,
symptoms.
good afternoon. Good afternoon. Good afternoon.
Good afternoon.
Yeah, I'm asking, is it every time I have a kid and is wheezing that I should first think of pneumonia or even other allergens can trigger that? Thank you.
I didn't get your name. Thanks for the question. I didn't get your name. Where you're calling in from?
Mulago. I'm calling from within Mulago here.
You're calling from within Mulago.
Makerere. This
Okay.
side of Epidemiology.
All right, thank you so much. We have Dr. Nantai, who is going to be giving us a case presentation, and she will elaborate on the clinical presentation, when you think you should be suspecting pneumonia, when you think it is least likely to suspect the pneumonia, and all that. Okay, I think we can set the ball rolling with our case presentation as we wait for some of your expectations on the group. I'll hand over the mic to Dr. Nantai to start the case presentation, and then it will help answer some of these questions.
Good afternoon, everyone, once again. I'm called Dr. Nantai Sherina from St. Francis Hospital in Zambia. So I'll be taking us through the case presentation, approach to a child with pneumonia, a case we had at Zambia Hospital. So we had EM, was a 4-year-old male, was brought in by the parents with difficulty in breathing for about 7 hours and fast breathing for a whole day. So from our emergency assessment of the patient at presentation, using our ABC, the airway and the C-spine, the child was really crying. So that was implying that the air was patent, so we didn't do anything about it. Then breathing, from us assessing the child's breathing, the respiratory rate was 48. The oxygen was between 85 to 88 on room air, and on oxygen it would go up to 98 via nasal prongs. Then the child also had a productive cough. So on examination further, the child had some nasal flaring and also some mild subcostal recession. So on auscultation, the child had diffuse post-crackles, which were in all lung fields, and also had occasional bronchitis had bilateral. So the plan there was to nebulize the child with 2.5 milligrams of salbutamol in 5 ml of normal saline every 20 minutes, and then reassess after 2 doses. Then also we keep the child on oxygen via nasal bronchs, and then also do a head tilt. Assessing the saturation, the BP was not done, we did not have an appropriate curve. Then pulse rate was 140. The capillary fill was less than 2 seconds, and the child had warm peripheries. So the heart sound 1 and 2 were hard, and there were no added sounds. So assessing the situation, we started an IV cannula. We collected blood samples for investigation, full blood count, malaria, and then at that time we did an MRDT, which was negative. Then continuing further on the disability, the RBS was 4.8, the GCS was 15 out of 15. The child was alert and the child was fully cautious. Both pupils were equal and reactive to light. The neck was soft, so we did nothing. And then exposure. So on exposure, the child had no obvious trauma noted. Also, the child was febrile. The weight was 38 point, rather the temperature was 38.1. And then intervention, we exposed the child. We gave rectoparacetamol. And then also we gave IV ceftriaxone 800 milligrams in suspense for any sepsis before we go further. Then the history from the sample, signs and symptoms, the child presented with difficulty in breathing, which was for 7 hours. The child also had high-grade fevers and had fast breathing. So from the allergies, there were no known food or drug allergies. Medications, They were on azithromycin and apidone syrup. Then the past medical history, the mother noted that the child had been previously treated from a peripheral clinic and was given azithromycin and apidone syrup. However, there was no improvement. There were no known chronic illnesses. Then the last meal, it was unknown. Then events, the mother reported the child was generally unwell for the last 2 days. The child had a runny nose and a productive cough associated with fevers, which were worse in the night. However, 7 hours prior to admission, that's when they developed the difficulty in breathing and fast breathing. That was a bit of our history of presenting complaint. So our problem list, we had respiratory distress and the high-grade fevers. So from our tests done, we are doing for CBC and malaria. So we noted that our RD2 was negative. The BS, there were no malaria parasites seen. Then from the full blood, 3 was almost normal. The absolute neutrophil count was 2.4. Absolute lymphocyte count was 2.3, which was also almost normal. HB was okay. Then the platelets were also okay, 488. Then our impression at that time was a fire with pneumonia in view of the difficulty in breathing, fast breathing, and on examination, they had really diffuse crackles and an occasional bronchi. Then our treatment and follow-up, the plan was to admit the child to our ward, St. Teresa ward, and the child was started on nebulization with salbutamol, 2.5 milligrams of normal saline every 2 seconds, every 20 minutes, and we were to give 2 doses, then reassess. And then if the child was better, we switch to 6 hourly, then continue with ceftriaxone, 800 milligrams OD, keep on oxygen via nasal prongs, and then also monitor the patient vitals. Then from the patient follow-up, we had the follow-up from day 1, day 2, and day 3. So day 1, reassessing the child, we reviewed a 4-year-old male who was being managed for pneumonia, so that at that time, the mother reported that there was improvement. However, the child had a wet cough. So the examination, the child was in a fair general condition. The child was now febrile, not pale, not jaundice, no cyanosis. Respiratory exam, the child was in mild respiratory distress, had a doctoral session, respiratory rate was better, 35. The SpO2 was 88 to 90 on room air, had bilateral echo entry, had still had the diffuse crackles, and then also had the occasional bronchi. Then oxygen saturation on oxygen was between 95 to 98 via nasal prongs. So the other systems were really unremarkable. So the plan at that moment was to continue with the IV ceftriaxone, continue the nebulization, 2.5 milligrams in 3 meals of normal saline, but this time 6 hourly, then keep on oxygen via nasal prongs. And then also we added on a syrup mucosil, which was to be given 500 mils every 8 hourly. Then assessment on day 2, the mother reported there were no new concerns. There were no new concerns, the child was better. In examination, the child was in a fair general condition, a febrile, not pale, no jaundice. And this time around, the child was not in distress. Respiratory rate was 26. SpO2 was 98 on room air, and had bilateral echo entry and had some occasional bronchi, and other systems were okay, they were unremarkable. Then the plan was to continue with the IV ceftriaxone nebulization. We switched to 8 hourly, then monitor the oxygen levels. We wind off the oxygen, the plan was to monitor oxygen levels for that day, and then also continue with the mucosil syrup. Then on day 3, we reviewed the child being managed for pneumonia, and the child there were no new concerns. The baby was really playing. On examination, the baby was in a fair general condition. Child was not pale, no jaundice, not dehydrated, and the respiratory exam was not in distress. Respiratory rate was 28. Saturation was 98 on room air. Had bilateral echo entry. The chest was now clear, and other systems were unremarkable. So we stopped the nebulization. The plan was to discharge the baby. We switched to oral. We switched to oral cefixime. Then also continue with the mucosal syrup and review the child after 5 days, which was on 24th. Thank you.
Thank you so much, Dr. Sharina, for that case presentation. It has been very elaborate, very detailed in terms of flagship management approach, reviews. We thank you so much for the good work. I would like to request the participants, maybe 2 or 3, to have some few questions directed to the presenter, the former presenter who just gave us the case. I'll be taking 2 or 3. One of the questions is, why did you manage it as pneumonia and not severe pneumonia?
Thank you. So when it had pneumonia, depending on how the child presented, the distress was not very severe. The distress was not severe. So when we assessed our parameters, they were not falling into the severe part of the pneumonia. So that's how we managed as a pneumonia.
Thank you so much, Dr. Natai. Someone is asking, why not discharge on azithromycin in view of mycoplasma pneumonia? I think this one will be responded to by the pediatrician who will be coming in shortly to make her presentation. She will maybe handle better the management bit. I request that we go to the expert presenter. I don't see hands. I have some few hands. I'll give maybe one of them an audience. Let's hear from Elizabeth Nalubanga. Your question, please.
Yes, good afternoon. Thank you so much for the presentation. My question is, why didn't you tell us, okay, you mentioned about your findings. The child had bronchi and crackles at the same time. I expected you to tell me that you're managing both a bronchiolitis and a pneumonia, not just pneumonia alone. How come that didn't come out very well? Or are we sure that the child didn't have any history of asthma? Yes, that's what I want to clarify on.
Thank you so much. I request that the next presenter who is going to help differentiate all those will best answer that question. Mugisha Godfrey, can I hear from you? Please.
Thank you very much, presenter, for the presentation. My concern is on the diagnosis of a pneumonia, and when someone asked, and then she says, depending on the presentation. But when you reflect on the part of the management, you see that you nebulize, you are nebulizing 6 hourly. The child was even put on oxygen. And then there, I don't feel convinced when you tell me that it's a pneumonia, not a severe pneumonia, for someone who is on oxygen. Thank you.
Thank you. For what I was trying to say, depending on the severity of the respiratory distress, we have the mild, moderate, and severe. So there's a time when we have the mild, we keep on oxygen via nasopharynx. Then there's where we continue to opt flow. Then we continue actually even ventilation. For our baby, really, we're managing on the least amount of oxygen, which was nasopharynx. So we didn't think it was severe pneumonia. Then someone asked about why we discharged on civicism, not as it was. So we realized that in our past medical history, the child had been on azithromycin and Epidemiology. However, there was no much improvement. Thank you.
Thank you so much, Mugisha, and also Dr. Lantai, for those clarifications. I think I was suggesting we go into the medical management and then we shall answer those questions into detail better. So at this moment, I would like to invite the next presenter, who is Dr. Lisa Ryan, a pediatrician from Mbale, Busitema University. Welcome. Please go on with your presentation.
Thank you. Are you guys going to share slides, or would you like me to?
I think we can share the slides from here.
Okay, great. Okay, perfect. Thank you so much. So I'm going to go ahead and hopefully answer some of the questions that have been raised about the management and presentation of pneumonia in children. I will go to the next slide. So I always like to start with explaining why we need to care about a topic. And so if you go to the next slide, please. So globally, one child dies of pneumonia every 39 seconds. That means that during the course of this session, over 100 children will die somewhere in the world from pneumonia, and there will be approximately 800,000 deaths over the course of the year as a result of pneumonia in children. 50% of both pneumonia cases and deaths are in sub-Saharan Africa, with approximately 80% of all episodes occurring in children younger than the age of 8 years old. There's a disproportionate amount of the mortality in children under the age of 1 month. In Africa, pneumonia causes approximately as many child deaths as malaria. And in Uganda, where I know the majority of the participants are joining from, pneumonia remains the second leading cause of all hospital admissions among children less than 5 years old. So while there's been progress in reducing the disease burden with improved vaccination coverage and the introduction of the pneumococcal conjugate vaccine, these numbers emphasize the importance of prompt recognition and appropriate management of these patients. So we'll kind of walk through a little bit of the clinical features and definitions, because that seemed to be where a lot of the questions were coming up. So pneumonia, as the presence of fever, cough, tachypnea, respiratory distress, and the finding of abnormal breath sounds on auscultation. Pneumonia is often further described as bronchopneumonia, which involves the lung parenchyma and the bronchi, or lobar pneumonia, which involves one or more lobes of the lung. Pneumonia can be caused by either viruses or bacteria. Less commonly, it can be caused by parasites and fungi, and the etiology varies depending on patient age and risk factors. I saw it in some of the questions that there were lots of questions about how to differentiate these. And unfortunately, it's not usually possible to determine the specific cause of pneumonia by clinical features or chest X-ray findings. It's really a combination of the two and incorporation of kind of age and risk factors that might be present. Pneumonia in children is further classified as either severe or non-severe based on clinical features present, and management is based on the classification. So we'll discuss these in more detail shortly. The clinical features of pneumonia in children vary immensely between individual patients and different ages. So most children with pneumonia will have some degree of respiratory distress, fever, and cough. Some children will experience chest pain. This is particularly common with cough or deep inspiratory effort. Many children will have decreased appetite or decreased breastfeeding can be present in infants. Breastfeeding infants can be thought of as breastfeeding in infants can be thought of as baby exercise. And so any changes in an infant's ability to breastfeed can be an early indicator of distress, and can be really important to recognize in a patient who might not otherwise be able to clearly communicate changes. Vomiting and abdominal pain are particularly common in lower lobe pneumonias. While there were lots of questions present about kind of the use of salbutamol and nebulizing, but while wheezing may be present in other illnesses such as asthma or foreign body ingestion, it can also be present in pneumonia. Or alternatively, you could have a child who has asthma that is exacerbated by pneumonia, and therefore wheezing can be present. More ominous findings may include lethargy, decreased responsiveness, cyanosis, and seizures. Next slide, please. So as we talk about the signs of pneumonia in children, I wanted to briefly discuss the signs of respiratory distress and age-specific criteria for tachypnea. So signs of respiratory distress may include chest indrawing. This includes suprasternal, subcostal, and intercostal retractions. And I kind of think of those as a progression in severity of the respiratory distress. So if you think about you can make suprasternal retractions, subcostal take a little bit more work, and it's difficult to generate intercostal retractions without having a disease process present. Nasal flaring, tripod positioning, grunting, and cyanosis can all also be signs of respiratory distress. Tachypnea is almost always present in children with pneumonia. So it's probably one of the most sensitive markers. However, it's important to interpret the respiratory rate based on the child's age. So from 0 to 2 months, greater than 60 breaths per minute is considered tachypnic. 2 to 12 months, more than 50 breaths per minute. 1 to 5 years, more than 40 breaths per minute, and more than 5 years is greater than 30 breaths per minute. Okay. So as most of you may know, an easy way to start an argument is to tell a pediatrician that children are just small adults. So I just wanted to take a quick opportunity to remind you that they're not, and why we care so much about respiratory distress in children. So children are more susceptible to respiratory distress when compared to adults for several reasons. Infants are obligate nose breathers. So this means that nasal congestion and secretions can cause significant distress in this age group. So a lot of congestion or secretions in the nose are a lot more troublesome when you're an obligate nose breather. They have smaller airways, which makes it easier for them to become obstructed with inflammation and mucus plugging. They have more compliant chest walls, which results in lower forced residual capacity. Ribs are oriented more horizontally, expand the lungs. And finally, they have less hypoxic drive when compared to adults, which makes them more vulnerable to respiratory distress. So all of this combines to why they suffer a higher mortality rate from pneumonia and respiratory processes, and why they can become sicker as a result of these processes quicker. We won't spend a lot of time on this slide, but I wanted to provide a very brief overview of some of the key clinical features that differentiate pneumonia in children from some other common respiratory infections and causes of respiratory distress in the pediatric population. So these are not mutually exclusive. So it's possible, as I mentioned before, for a child with asthma to also have pneumonia. And the presence of pneumonia can exacerbate kind of the underlying asthma in a patient, or a patient who might have aspirated a foreign body can develop a secondary pneumonia. So as we go through this, I think about pneumonia as being cough with fast breathing and fever, typically develop over a couple of days, and will have the presence of crepitations on auscultation. Asthma should have more of a chronic history with kind of known triggers or exacerbations, and will respond to bronchodilators. Foreign body should be more of a sudden onset and doesn't always have the infectious signs. So often there's absence of fever at the initial presentation and more of a sudden onset of stridor or respiratory distress. And then things like retropharyngeal abscesses will have more sore throat accompanied with a fever and fewer symptoms associated with like lower respiratory tract involvement. And croups should present with the characteristic barking cough and hoarse voice, along with an upper respiratory tract inspiratory stridor. And so a couple of key features there that help differentiate some of the common presentations for respiratory distress. Okay. So again, important to remember that not every respiratory illness in children is pneumonia, although we certainly want to be aware of it given its high mortality and prevalence. So many children that present with respiratory illnesses might have a normal cough or cold virus. These include things like rhinovirus and adenoviruses and coronaviruses and parainfluenzas. And treatment of these illnesses should be supportive and does not require treatment with antibiotics. Children should be discharged home with guidance on how to soothe the throat and relieve cough. There are lots and lots of questions about how you get rid of cough in children. Unfortunately, despite a lot of research, there's no good intervention that has been proven effective in reducing or eliminating the presence of cough in children. Honey has proven to be one of the most effective and safe remedies for cough and sore throat in children over the age of 1. And I often approach this with parents as trying to explain to them that I don't want to take away a child's kind of cough, because that's their way of clearing the mucus and out of their airway, and a really useful protective mechanism for them, despite it being really frustrating. So there's a lot of parental education and guidance that goes along with the presence of cough, and reassurance that the cough is a protective mechanism. But again, honey has been shown to be one of the more effective and safe interventions. Education should be provided on when to return for review. This includes if symptoms worsen, signs of distress, or inability to feed, and follow-up should be advised if the child is not improving within 5 days to reevaluate the evolution of symptoms. Pneumonia. So we'll start with non-severe, I know lots of questions about how do you manage and differentiate the two. And so non-severe pneumonia in children is classified as children with fever, cough, and fast breathing. So again, we define fast breathing as greater than or equal to 50 breaths per minute in a child 2 to 11 months old, or greater than equal to 40 breaths per minute in a child age 1 to 5 years, greater than 30 breaths per minute in a child over the age of 5 years, along with chest indrawing, which we remember is a sign of respiratory distress. You'll notice that infants under the age of 2 months are not included in this category. So in infants, although there are many reasons for respiratory distress, and not all respiratory distress is due to infection, pneumonia can be rapidly fatal in this age group, and therefore any suspected cases should be treated promptly and referred for IV treatment with antibiotics, and therefore all children under the age of 2 months with suspected pneumonia are considered as having severe disease. So if we move on to severe pneumonia, signs and symptoms of severe pneumonia in children include fever, cough or difficulty in breathing, with an additional finding of an oxygen saturation of less than 90% in room air, or signs of central cyanosis, which the patient in the case presentation had as they came in satting less than 90%. Severe respiratory distress, which may include grunting or severe indrawing, or signs of pneumonia with a danger sign. So these include inability to breastfeed in younger children, lethargy, or a reduced level of consciousness. The common causative organisms for pneumonia vary by age. So as with most things in pediatrics, it's not quite one size fits all. And so in neonates, the causative organisms are largely due to exposure to the maternal urogenital tract during delivery. So the common organisms include group B streptococcus, Klebsiella pneumonia, E. coli, chlamydia, and Staphylococcus aureus. In children under the age of 5 years, the causative organisms change to become those that can be spread through respiratory contact. These include strep pneumonia, Haemophilus influenza, Staph aureus, Marxella, Mycoplasma pneumonia, which might often be called atypical or a walking pneumonia, and many different viruses such as RSV, influenza, and measles. In adults and children over the age of 5 years, the most common organisms again include strep pneumonia, Mycoplasma, and again, many different viruses. TB can be suspected in a child with persistent cough and fever for more than 2 weeks and signs of pneumonia after adequate antibiotic treatment. So it can be considered in any of these age groups, but with the appropriate clinical history. And then another special subgroup would be children with HIV infection, who is important to remember that can have the same bacterial etiologies as any child without HIV, but with the additional risk factor for pneumocystis, depending on their immune status. Okay, lots and lots of questions about labs and imaging. So pneumonia in children can and often is a clinical diagnosis. And so no lab investigation or X-ray is required for the diagnosis of pneumonia in children. However, there are some investigations that, when available, may be helpful. In endemic areas such as Uganda, a blood smear or malaria rapid diagnostic test is always an acceptable investigation for a child presenting with fever. It is possible for malaria to cause significant tachypnea from fever or severe anemia, and therefore it should remain on the differential and investigated appropriately in any patient presenting with those symptoms. Obtaining a complete blood count should be considered to evaluate for the presence of leukocytosis. However, as we saw in the case presentation, this finding may not always be present and lacks both sensitivity and specificity in the diagnosis of pneumonia in children. So studies have consistently shown that leukocytosis alone is a poor predictor of pneumonia etiology and severity. Although other studies have kind of shown that higher white counts, so greater than 15,000 or kind of increasing specificity with greater than 25,000, have been shown to be associated with more severe pneumonias. The Pediatric Infectious Disease Society recommends CBC should only be obtained in cases of severe pneumonia, and so not necessary in patients with non-severe pneumonia. Chest X-ray has good specificity and sensitivity for diagnosing pneumonia in children, although it should be noted that findings on chest X-ray may lag behind clinical symptoms by several days. Therefore, a negative chest X-ray obtained at the beginning of symptoms may not show any signs of pneumonia and could be falsely reassuring. Other investigations that one might consider might include a gene expert, culture, sputum, and that's all going to be dependent on your history. Okay, we'll move on to management. So as with any emergency, the management of a child with pneumonia should be initially approached utilizing the ABCDE method, as was done in the case presentation. So these children are at risk of airway compromise due to decreased levels of consciousness resulting from underlying illness. So we saw that in severe pneumonia, one of the findings is kind of decreased level of consciousness or lethargy, which can impair the child's ability to protect their airway. Breathing can be compromised due to the effects of pneumonia on the lungs. Assessment of breathing should include respiratory rate, pulse oximetry, assessment of work of breathing, and auscultation. Assessment of circulation and volume status is particularly important, as children with pneumonia may have dehydration secondary to poor PO or signs of shock due to infection. And temperature and blood glucose can be abnormal as a result of illness or poor PO intake. Exposure to pathogens such as malaria should be identified, along with any medications that have been administered prior to arrival. Okay. Management of pneumonia. So children classified as having non-severe pneumonia. So again, these were children without respiratory distress and normal oxygen saturations, can be managed as an outpatient. The preferred first-line antibiotic for these children is oral amoxicillin at a dose of 40 milligrams per kilogram per dose twice daily for 5 days. Parents should be instructed on how to give the medication at home to ensure safety and adherence to the prescribed dosage. Salbutamol and paracetamol can be given. So paracetamol at 10 to 15 milligrams per kilogram every 4 to 6 hours as needed for fever or pain. And salbutamol can be considered at a dose of 1 to 2 puffs every 4 to 6 hours if wheezing is present. And so again, it doesn't really have a role in the cases of pneumonia without any wheezing. But if wheezing is present, it can be considered. However, it's important if you're doing this and an inhaler is being prescribed that the parents are educated on the correct technique and use of a spacer device prior to discharge so that they receive the benefit of the prescribed medicine. Mucolytics and cough syrup, such as the mucosal syrup used in the case presented, should be used with caution in children. So they generally have not proven to have a lot of benefit, and providers should be cautious of potential side effects. Management of severe pneumonia is a little bit more nuanced, and I saw, again, lots of questions about this. But the preferred first-line antibiotic for children with severe pneumonia is ampicillin or benzicillin and gentamicin. And this is dosed at ampicillin 50 milligrams per kilogram or benzopenicillin at 50,000 units per kilogram, IM or IV every 6 hours for at least 5 days, and gentamicin 7.5 milligrams per kilogram, IM or IV once a daily for at least 5 days. If the child does not show signs of improvement within 48 hours and a staphylococcal pneumonia is suspected, antibiotics should be changed to include gentamicin and cloxacillin so that you expand your coverage to include Staph aureus. Clindamycin can also be considered if MRSA is suspected or if there's a need to give an oral antibiotic rather than an IV or IM. As we saw in the case presented and is common in many hospital settings, ceftriaxone can be used to treat pneumonia in children. However, it should be acknowledged that according to guidelines, it should be used in the case of failure to adequately respond to first-line treatment. It's once daily dosing makes it an appealing option in many settings where staff is limited and more frequent dosing may not reliably occur, but per guidelines, it is not a first-line choice. Supportive care of a patient with severe pneumonia includes things like removing any secretions, so suctioning out any secretions at the entrance to the nasal passage or throat, which the child cannot clear on their own. If the child has a fever, which appears to be causing distress, giving paracetamol. If wheezing is present, giving a rapid acting bronchodilator such as salbutamol, and starting steroids when appropriate. So if the child had a history of asthma or reactive airway disease, bronchodilators and steroids certainly might play a role, but it would be dependent on the history. And ensuring that the child receives daily maintenance fluids appropriate for his or her age if they're not taking adequate oral fluids or PO intake. supplemental oxygen. As was present in the case presented, children with severe pneumonia may have hypoxia and require supplemental oxygen as part of their management. Children with a pulse oximetry reading of less than 90% should receive supplemental oxygen. This can be via nasal cannula, face mask, or CPAP, depending on what is available and clinically indicated for your patient. So nasal prongs are the preferred method of oxygen delivery in children. Standard flow rates for oxygen through nasal prongs or nasal catheters are generally thought of as 0.5 to 1 liter per minute for neonates, 1 to 2 liters per minute for infants, and 1 to 4 liters per minute for older children. Higher flow rates without effective humidification can cause drying of the nasal mucosa and can be associated with bleeding. However, these are, if you're kind of required to choose airway and breathing over mucosal irritation, you would absolutely do that and increase your flow if clinically necessary. And these numbers are meant to be a guideline and can be adjusted based on the clinical scenario. Face masks allow for delivery of higher flow, and so might be better tolerated in some patients. However, they're unable to generate any PEEP. And so in smaller infants where nasal cannula can facilitate by giving some additional positive pressure to their airways and assisting with work of breathing, face masks don't have this added benefit. CPAP or continuous positive airway pressure can be used in children who have moderate or severe increased work of breathing or hypoxia that is not adequately improved with other forms of supplemental oxygen. As the name indicates, CPAP provides continued pressure support to the lungs, therefore decreasing atelectasis, reducing work of breathing, and improving oxygen delivery. And so definitely an option in a patient with severe respiratory distress who you think nasal cannula is not providing adequate relief. So this diagram shows how to make an improvised bubble CPAP machine. I'm not going to describe this in detail now because as part of the session, we'll have an instructional video made by some of the amazing pediatric SHOs in Mbale who will go through step-by-step its setup and uses for you. Okay, so this slide is congested, but summarizes the information presented regarding the classification, signs and symptoms, and treatment of no pneumonia, pneumonia, and severe pneumonia in children. Key points include that children with no pneumonia, so those with no signs of pneumonia or severe pneumonia, may be managed at home and without antibiotics. Children with non-severe pneumonia can also be managed at home with oral antibiotics, but should be provided with appropriate education and follow-up. And children with severe pneumonia should be admitted to the hospital, treated with IV antibiotics, and provided supplemental oxygen as needed. Complications of pneumonia. So in children, septicemia is the most common complication of pneumonia and occurs when the bacteria causing the pneumonia spreads into the bloodstream. The spread of bacteria can lead to septic shock or metastatic secondary infections. So we might see meningitis in an infant with a more permeable blood-brain barrier. Peritonitis can be present. Children with valvular heart disease might develop endocarditis or septic arthritis. So kind of a secondary infection as a result of the spread of the bacteria that initially caused the pneumonia. Pleural effusions and empyema should be drained unless very small and treated with 7 days of IV or IM antibiotics. If you were to see a pleural effusion or empyema, that to me would be a trigger to expand your antibiotic coverage to Staph aureus. That's one of the more common bacteria that causes this particular pleural effusions and empyemas in children. So I would change to ecloxacillin or clindamycin in those patients. Less commonly, abscesses can occur, and pneumothorax is an additional complication, although rare in children. while we've talked about the presentation and management and complications of pneumonia in children, I think it's also important, and I wouldn't be a good pediatrician if I didn't address prevention. And so we can help prevent some of the mortality and morbidity associated with pneumonia in children by continuing to encourage exclusive breastfeeding until 6 months of age, because this allows the infant to benefit from the antibodies they receive from the mother's breast milk, reducing exposure to indoor air pollution, so trying to discourage indoor fires and cooking. Good hand hygiene reduces the risk of infections spreading among children, preventing and treating malnutrition, as these children are particularly at risk for developing pneumonia, and then encouraging adherence to the routine vaccine schedules for children. So Uganda introduced the pneumococcal conjugate vaccine in 2013. And so this has had significant benefits in reducing the incidence and prevalence of pneumonia in children. And so really kind of amazing benefits that can be seen by just encouraging adherence to routine health maintenance. And that is all I have. So those are some references. And I will turn it over to Sister Doreen, who will talk about some of the nursing care associated with children with pneumonia.
Thank you so much, Dr. Lisa from Bale. That was very detailed, very elaborate. I think it answers a lot of the questions it answered most of the expectations people had for this particular discussion. There are a few things I would like to also add on. Usually in our setting, we don't have very good diagnostics, but in case we want to classify your pneumonia in terms of severity, whether it is mildly severe, moderately severe, or like very severe, you can use your clinical findings on the chest. So usually mild pneumonias will present with like chest indrawing. Usually severity goes from down to up. So I mean from the chest. So if you get your examination findings having like chest wall indrawing, maybe subcostal recession, that should point to a mild pneumonia. And then as you come up to, let's say, intercostal recessions and maybe with sternal notching, that is like a mild. So if you get symptoms that go and evolve in the head, like nasal flaring, obvious head bobbing, that should point you to severe pneumonia. Maybe that can also help with trying to differentiate the severity of pneumonia. And then the other thing, someone asked about drug resistance. When do you plan to switch? So the ideal is we have a lot of drug resistances because anyone seems to prescribe treatments, but also sometimes the patients or the parents, when you prescribe today amoxicillin and it works, they will not come back to the hospital. It's like every time they'll keep buying that and giving, and with time you get resistances. But you usually, when the patient comes to the hospital and you initiate treatment, and within 48 to 72 hours, you're not seeing improvement, then there is need to switch. Usually by this time, maybe you'll have gotten culture results, but if you also don't have culture results, usually by day 3, you should be getting an improvement. Because when you're managing pneumonia, sometimes, actually most of the times, the initial management, like the patient first worsens and then they later recover. So, but we give a window of 48 to 72 hours for a change of antibiotics. Someone else talked about dosing of ampicillin and also ceftriaxone. So it depends. If you have like a severe form of septicemia, let's say meningitis, you want to go higher doses. So the doses usually range from 50 to 100. So if you're having pneumonia, we usually take the lower side as we keep the higher doses for more complicated things like pneumonias. So I think that answers. And most of the questions, Dr. Doreen is doing a good job in the Q&A. Kindly check out there and you'll find most of the answers in there. Thank you so much, Dr. Lisa, for the elaborate presentation. At this juncture, I could get 2 questions. Just raise your hand and then Dr. Lisa can answer maybe 2 questions from the audience. Let's have Anna. Anna, please unmute and ask your question. Okay. If Anna is not getting through, let's have Jackson. Jackson, kindly unmute and ask your question.
Good afternoon, all.
Good
afternoon.
Thank you, the guest presenter and the expert presenter for the presentation. My question is about the suspicion index for drug resistance, more so when you're dealing with children below 5 years. When in the clinical, how much or to what extent should a clinician suspect a drug resistance when you're dealing with PID? Because my thought is when children are still young, 2 years, 1 year, the exposure to antibiotics isn't yet that much. So should we really have a very high suspicion index, or we can keep it low? Thank you.
So I would say, yeah, that's a great question. I would say that the index of suspicion is generally lower in children who haven't had as much time and exposure to antibiotics. However, if they're around lots of adults or kind of a setting where they might be exposed to resistant bacteria, then that's possible. I always kind of think about it as kind of how much room do I have to be wrong when I'm treating? And so a child who comes in with mild symptoms, I will approach them with first-line antibiotics, watch for 48 to 72 hours, and expect that they should start to show signs of improvement within that time. If a child comes in with very severe symptoms and I have less room to be wrong in their care, less room to kind of allow them to worsen, then I might be a little bit more aggressive and make that change more in the 24 to 48 hour time period. And so it just kind of depends on the clinical situation and what the child looks like.
Okay, thank you so much, Dr. Lisa. Let's have a second question from Praise Niwamanya.
Well, thank you. Back to pneumonia, most of these kids and young children always present with that cough. Some may be productive and at times non-productive. And then after completion of treatment and after giving other rated drugs, there is always persistent of that cough. That cough always persists even after completion of treatment. So you finish working upon a patient, but again, she still comes to you complaining of cough. So I don't know which best drugs can be used for that.
Yeah, it's tough. Every parent wants the cough to go away because it keeps them up at night and it irritates the child and it's not comfortable. And so I think part of that is explaining to the parent and taking the time to kind of explain that the cough is often the last symptom of kind of any respiratory illness, whether it be a common cold or a pneumonia that resolves. And so the fever and kind of go away and the child will start to gain their energy back and their appetite back, but the cough will often persist beyond the resolution of the other symptoms. And that is part of the child's own protective mechanisms and kind of the immune defense against bacteria. And so as much as that cough is frustrating, making it go away kind of traps all of that bacteria and mucus inside their chest, and that's not where we want it either. Sometimes it's productive and sometimes it's less productive, especially younger children who might not be able to generate as much force with their cough. And so that's why often in children, it lingers a little bit longer because they're less effective at clearing all of the mucus out of their chest. And so it takes them a little bit longer. But a lot of it is just reassuring the parents that I know it's frustrating. I know you want this to go away, but the cough is the last thing that's going to get better. And here's how I know your child is improving and the infection is resolving, even though the cough is still there.
Thank you so much, Dr. Lisa, for that elaborate explanation. There is someone who is wondering how the pneumonia is going to lead up to pneumothorax. Kindly answer that, and then we can go on.
So sometimes it's just from the pressure generated from kind of persistent strong cough. Sometimes we can generate a pneumothorax if by using too much pressure, if we're treating the patient with continuous positive airway pressure at kind of pressures that exceed what would be appropriate for that child. And so it just, it can be for a variety of reasons that you could potentially develop that. Like I said, it's uncommon in children, but can occur.
Thank you so much. I think that answers most of ours, but please keep those questions coming. Dr. Doreen will be answering them in the chat, and as well as Dr. Lisa can keep answering them. So thank you for that presentation, Dr. Lisa. Let's go to our next presenter, who is Miss Doreen Katushave from Mbarara Regional Referral Hospital, Neonatal Unit. She will be telling us what the nurse is supposed to do in terms of managing a patient with a baby or a child with pneumonia. You're welcome, Doreen.
Thank you very much. I was trying to unmute. Am I loud and clear?
Yes.
Yes. Yes?
Yes, you are. Yes.
Okay, thank you very much. Yeah, like the moderator said, my name is Katushave Doreen. I'm from Mbarara Regional Referral Hospital. I'm a critical care nurse. Currently, I'm the in charge of the neonatal unit. So this is just something that we should know, but good enough, Dr. Lisa had talked about it. So I will not take much time here, but just to emphasize that pneumonia is actually, it was one of the leading causes of death among children, but that was in 2019. And like she said, half of them were in sub-Saharan Africa. Right now, it is the second leading cause of admissions and deaths in under 5 in Uganda. The first one is malaria. Then right now, the mortality rate is actually 40 per 1,000 live births. However, this is from 180 in 1990. So somehow we are doing something good. SDG 3 targets that by 2030, we should be able to have a reduced mortality, which will be about 25 per 1,000. So see us from 40 to 25. We still have a long way to go. Next slide, please. Now, as a nurse, we should all know that nursing is universal. And this is from the need for nursing is universal as per the International Council of Nurses. The nursing process is a language we use as nurses. It is a language that unifies us. So the doctors who may not know the nursing process, welcome to the language of unity. Now, nursing process is a scientific and a systematic way that we are able to provide care. It gives us a framework where we work with as nurses. It is goal-oriented, and it is a method that is recommended by everyone. At least every nurse should be using this. So it provides individualized care for clients in all states of health, and we focus on achieving outcomes in a cost-effective manner. Next slide, please. So we have 5 steps. I'm going through this for the sake of people who may not know nursing process and to make it easier ahead. We have the assessment. This is the initial stage. In assessment, like how you saw Dr. Natai do it, she started with her ABCD. So you want to assess and find out what is wrong with this patient. You want to see the good and the bad, yeah? And then we have what they call the nursing diagnosis. We are diagonizing, we're coming back, we are coming up with a problem after doing an assessment. Then we plan and we have goals. So you want to know at the end of the day, what will my outcomes be like? Then after planning, you implement. So you have a plan and then you act upon the plan. Then after acting upon the plan, which we call the implementation, we will evaluate what we did. Was it useful or not? Do we have to go back and change something? And so you should note that this nursing process, the steps are cyclical. Like you can move from evaluation, you come back to the planning phase and you see where you can adjust, then you implement. At the same time, maybe you could have missed something, so you can actually go back up to nursing diagnosis or even assessment if you missed something. Next slide, please. So when we are assessing, you can either use the focused or the comprehensive assessment. However, for a very sick child, for example, the child we had, I would prefer the focused. And then so the focus is about you get to know what the problem is, and then you deal with the problem, then you can continue to do a general assessment. Now, as we are dealing with babies or children, remember the mother, who is the primary caretaker, is the person that the baby will trust, the child will trust. So nurses, please, as you're starting your work, kindly introduce yourself, try to create a rapport with the mother, then allay anxiety. For parents, you can agree with me that when our babies are sick, you actually feel like if it were me who was sick at least, because you would talk and say, this is the problem, but the child may not be able to tell you. It is you to see that something is wrong and you act upon it. Also, we need to be empathetic, whether you have been a parent or not. When someone has a sick child, try to put yourself in their shoes and you'll understand what they are going through. Okay, so now for the children, this is a 4-year-old baby that we are talking about, child, sorry, not baby. You need to have a toy, something that is going to reduce anxiety. You need to be creative. Sometimes you can even give just a pen to the child. You try to distract them a bit as you're doing your assessment. Otherwise, some of these children fear strangers, so they may not let you do what you want to do. Okay, so we continue. Now, from our assessment, we come up with nursing concerns. If you remember what Dr. Nantai presented, part of the nursing concerns that I came up with are, this child had fast breathing, had a respiratory rate of 48. They gave us the normal ranges, and you would say at least 20 to 30. But if you go beyond 40, you're worried. I remember what Dr. Lisa was presenting. She gave us specific areas where you can talk about the respiratory rate and you say, yeah, this is pneumonia or this is severe pneumonia. The next one is decreased oxygenation. If you still recall, we had stats of about 85 to 88 on room air when the child had just arrived. Kindly permit me to keep saying baby because I'm used to babies. And then we had a fever of about 38.1. We also had a tachypnea. Okay, it was, I think, about 140. Yes, please. Let's continue. Next slide, please. Okay, so remember, we had talked about the nursing process, that we start with our nursing diagnosis. Let's continue to the next slide. We start with the nursing diagnosis, and then we go on with the planning, and then we intervene, and then we evaluate. So part of the nursing diagnoses that came out are these. So we realized that this child actually had ineffective airway clearance, and we are relating it to increased sputum production. When we talk about the related two factor, this is the etiology, what could have caused it. And the evidence that we have is post crackles, which were had in all lung fields. Then the second one is ineffective breathing pattern. This one, we are relating it to the inflammatory process. And the evidence we have is the dyspnea. The child also had subcostal recession, and also the respiratory rate was 48, which is tachypneic. It is tachypnea or tachypneic, yes. Then we had also impaired gas exchange. Here we are relating it to the alveolar capillary membrane changes. And with the evidence that we have is the hypoxemia. Our reading of SpO2 was about 85 to 88 at room air. It should be above 90. So below 90, we say we are having hypoxemia. Then we also had hypothermia. We are relating it to the infection. And the evidence that we had is the temperature reading of 38.1. Kindly, let's continue. So after diagnosing, now we want to work. We want to deal with the different diagnoses that we have come up with. And as nurses, we come up with what we call a nursing care plan. Our care plan has the diagnosis. Yes, we had already done the assessment. Then we have the diagnosis, and then we have the expected outcome. When you're going somewhere, you first look at where you're heading. You want to know the end before you can go there. So we talk about the expected outcome. At the end of this, what do I want? And then you're going to have your interventions, but every intervention has a rationale. We give a reason as to why we are doing something, and then we'll evaluate. Okay, so whatever goals we are setting should be smart, and we know that they should be able to, they are realistic, and they should be time bound, they should be achievable, yes, and they are specific. Specific, measurable, achievable, realistic, and time bound. They should be smart. Okay, let's continue. So the first nursing diagnosis, which we talked about as ineffective airway clearance. So we want this patient to be able to maintain a clear and open airway. And the evidence will be that these breath sounds will be normal. We won't be having the so-called, we won't be having the crackles that were there initially. And then this child should be able to cough up those secretions. And the time we're giving ourselves, given the patient's condition, is within at least 72 hours. Then our intervention, we have many interventions that can be from one goal. So first of all, we are going to assess the airway patency. Remember, they told us the child was able to cry. So initially that airway was patent. However, the lower airway, because of the crackles, so we have secretions that need to come out. So we are assessing the airway because we want to maintain a patent airway. Then we are going to auscultate. We are going to listen to those lungs. We want to hear normal sounds. So we auscultate every 4 hours. And the reason as to why we are doing this, we want to monitor the breath sounds regularly to note if there is a change or not. Then we encourage coughing, and we monitor the amount and the color, the order of the secretions. Now remember, this is a child. This is a child who you have to work with the mother hand in hand. Even when you're not there, the mother is there to help. They encourage the child to cough. Sometimes you have to cough so that the baby can learn what you're saying. Yes? Okay. Then we want to maintain, we want to give oxygen, but would want to give it humidified. Because when you give something humidified, it is going to help actually to reduce the thickness of the secretions. And then we are giving the prescribed antibiotics. They may prescribe the mucolytics. You noted some of the syrups. Then bronchodilators, where they had salbutamol, they were nebulizing. And then all these are meant to promote airway clearance. One, the antibiotic will help us with the infective agent, but the others, mucolytics, bronchodilators, actually going to help us reduce the airway resistance. And as this child coughs, the secretions will come out. Also, the breathing gets better. Then we need to coordinate physiotherapy, because at the end of the day, it is going to be continuous. You can't do something once, you need to do it over and over again to achieve something good at the end of the day. So there are some techniques, because this is a child who is 4 years, they may not obey everything you tell them. They may not follow all the commands. However, some techniques like percussion can help to move those secretions at least. So we mobilize them upwards, and then the baby may be able to cough. The child may cough them up. Then the mother, we have to health educate them. The mother, remember I was telling you, we involve this mother. They need to know what is happening. So we health educate them on how to care for such a baby. There's a lot that you may have to tell them. You have to allay anxiety, you have to listen to their concerns. And in doing this, we are able to work with them. So, let me see, hydration. Okay, so when we would want to hydrate the child as well, because as you give more fluids, it helps liquefy the secretions. They become less viscous. Now, on the part of evaluation, I don't know if you're able to see, part of the things that will help us to know if actually we have been successful or not. Initially, we had signs of respiratory distress. So we may hope to see that maybe there is no nasal flaring, or it has reduced. How is the dyspnea? So my evaluation was, and you go back on the, you could go back on the presentation and you see the case presenter showed us this child still had bronchi after 4 hours. However, the dyspnea had reduced, it was mild, the distress was mild. Okay, then later in 48 hours, we noted that yes, much as we had crackles, but we were getting better, and we're looking at the vitals that were given. So I would like to move to the next one. The next one is ineffective breathing pattern. The breathing pattern, we are talking about the depth, the rate, you know, how is the lung expansion. So we have ineffective breathing pattern, and we had related it to the inflammatory process. The evidence was dyspnea, subcostal recessions, tachypnea, and also the respiratory rate of 48. Here we want the patient. Someone says the volume is low. Are you able to hear me or increase? Okay.
Yes,
Let me try to.
The volume is okay. The volume is okay.
Okay.
Maybe as
Okay.
he said.
So the expected outcome is the patient will be able to maintain an effective breathing pattern. And the evidence we would want is, as they are breathing, they should be relaxed. We wouldn't see the subcostal recessions. And also, we would have a normal rate and the depth as well. And this still, I'm giving 72 hours, because even when you're giving treatment, you wouldn't expect a drastic change within a short time. Okay, so now part of the interventions here, I would want to observe the breathing pattern. And the reason is for me to be able to ascertain if there are changes in the pattern, whether for good, rather whether better or worse. Then I would want to place this child in a sitting up position, at least 45 degrees. So you want to be able to promote lung expansion. And then, are we able to see it or I move on? Okay, so part of the expected outcome be that this child's respiratory rate is in normal ranges, which we had said is 20 to 30 within the first 24 hours. That was my target. Then we ambulate. However, you need to be careful. Remember, as they ambulate, this can cause fatigue. So you ambulate what they can tolerate, something small, which is tolerable. Then the ambulation actually has to break secretion, and they keep moving out of airways. So we'll be able to assess and record our respiratory rate at least every 4 hours. That is our intervention. I think I cannot see that. Let me open this one. Okay. Yes, so we are going to assess and record the respiratory rate and the depth at least every 4 hours. And this is going to be followed up, or the reason is that we follow up and are able to do proper documentation. Then we will administer the bronchodilators, if any. Still, these are going to help us to facilitate respiration, but also help in dilating the airways. Now, we are going to encourage small but frequent meals. If the child is given a big meal at a go, this meal, or as the abdomen distends, it is going to push onto the diaphragm. So you don't want to overcrowd the diaphragm. You want them to get something small but frequent or regular, like you can say. Then we have to counsel and again health educate the mother. Remember, we're giving medication. We want them to understand why we are giving, what dose are we giving, at what time, and what are the possible side effects. So here we are promoting cooperation. We want to effectively communicate to the mother. We want them to trust us, and we are also encouraging family-centered care. If you remember, part of, I think, the health belief model talks about if someone gets to know what they are going to achieve at the end of the day, perceived benefits, they are going to help them actually be cooperative. Okay, so the third one is impaired gas exchange. This one, we are relating it to the alveolar and the capillary membrane changes. The evidence is the hypoxemia. Also, we have a tachycardia of 140. Now, our expected outcome is for this patient to be able to display appropriate oxygenation. We mean our SpO2 reading should be at least above 90%, and I'd given this 20 minutes. So in this way, the intervention would be, we maintain a clear airway, and we're going to assist this patient to mobilize and cough this secretion successfully. Then the reason as to why we are doing this, we want to facilitate these, the clearance of these secretions so that they keep coming out and the child coughs them. Then also, another expected outcome, we want this patient to be able to demonstrate appropriate actions to promote ventilation and oxygenation within 1 hour. Okay. Here, I would want to give oxygen, and Dr. Nantai, from the case presentation, they started with 3 liters. However, you can start low. You don't have to start high. Start low, titrate to effect. This particular child, they gave 3 liters, but start low, titrate to effect. Then the reason as to why we are giving this, our rationale is that we want to improve oxygenation to at least above 90%. Then we will do a pulse oximeter reading every 5 minutes while we are on oxygen therapy. We also want to monitor the reasons that we are monitoring the SpO2, and we want to know the effect of the oxygen therapy. Like I was saying, titrate to effect. Then at the same time, for us to be able to have good gaseous exchange, we're going to elevate the head of the bed. Still, I'm talking about 45 to 60. Then, so you're going to do, you may encourage the child to be changing position. We want the child to be comfortable. And also, as we change positions and keep them proper, we are helping to maximize the chest expansion, and we are mobilizing these secretions. Then at the point when we want them to come out, the child will be able to cough. Then all this should be able to improve ventilation. Secretions get out of those alveoli, we are able to do what? To breathe better. We're able to have solid exchange at that point. Now, my evaluation, the SpO2 initially, which was 88, rather 85 to 88. If we are on oxygen, we hope that it will be better. Before we even go to oxygen, if we're able to prop this child, you will notice that they had an SpO2 reading that went to 88 to 90, and that was on room air. Then on oxygen, it increased to 90. It increased to above 90, to about 92%. Now, our elevating the head of bed, our promoting that position of being propped up is going to help in encouraging Hello. Hello. Okay, let me continue. So in this kind of position, we would want our evaluation would be that actually the mother is encouraging this baby, the mother is encouraging the baby to, or is holding the baby in this particular position and encouraging the baby to cough. Next slide, please. I think that one. Okay. Yes. Thank you very much. I am done, but I would like to tell our nurses and those who may not understand the nursing process that this is a unity language that we actually want to encourage all nurses to use. It is not easy. People have tried it, but it is doable. So you may not have to do all, like you may not have to manage all the nursing diagnoses that you come up with, but at least manage priorities. Thank you very much. Once again, it's Kakshabe Doreen from Mbarara.
Thank you so much, the nursing team. Thank you so much, Doreen, for that detailed elaboration of how a nurse should take care of these patients. Okay, I'm going to be taking one question in the interest of time for Doreen to answer as we get a demonstration from Dr. Lisa. Just one question. Kindly put up your hand. I'll be taking only one question. And then some of the questions in the chat can be answered by Doreen, just for the interest of time.
I have noticed something. I think it was Asimwe. There's a comment by Asimwe.
Yes, please.
Have you seen that? There was a comment by Asimwe, but I'm not able to see it.
Okay.
I think it was a good comment where she talked about, I think, was it that person who talked about collaboration? Eh? Yes, as nurses who work in a multidisciplinary approach, I'm not able to see it, but thank you very much. And that is important to include, yes.
Okay, thank you so much. I think we shall, most of the rest of the questions, we shall answer them in the chat since there is no hand up. In the interest of time, let's go to the demo of the
Dr. Martha.
Yes,
Dr.
please.
Martha.
Yes, please.
There is something, one of the concerns was hypothermia. If someone has been observant enough, I did not manage hypothermia. And the reason as to why I didn't manage it, it's because this is something that most of the nurses are going to manage, hypothermia and pain. So that was like something simple. I thought we can move to these ones that maybe are rare. I hope that's okay.
Okay, thank you for bringing that up because hypothermia or temperature issues can also lead to mortality. Let's have the demo from Dr. Lisa. She will be telling us how to administer oxygen and also the use of CPAP, the continuous positive airway pressure. The mic is yours.
I won't be demoing it, but we have the video from some of our pediatric SHOs at Rwotomiya Peter who will demo it for you. Better than me.
Hi everyone, this is Dr. Joan Tanangija, pediatric resident, Rwotomiya University attached to Mbarara John Farr Hospital, together with my colleague,
Dr. Sam Okotel, a resident pediatric officer, Rwotomiya University, Uganda.
Today we are going to look at improvised CPAP, that is continuous positive airway pressure. And this, we are going to look at the indications. It is indicated for patients who are having respiratory distress, and it will help to keep the airway open, reduce the work of breathing, and also improve on the gas exchange. It can also be used when you find that the patient is having hypoxia. We don't allow CPAP for patients or for babies who are having facial or chest fractures, patients who are having pneumothorax or pneumomediastinum. This time I'm welcoming my colleague Dr. Sam to continue and show us how we are going to perfect what for our SPAP.
Thank you very much. In this, we will have a nasal cannula. We will have a giving set. We will have a razor blade or a pair of scissors. We will have water. In this demonstration, we have pre-labeled from 1 to 7 centimeters. If you have normal saline, you can still also use normal saline using the same markings. So we have the oxygen source. In this case, we will have the oxygen concentrator. But if you have oxygen cylinder, you can still use it. So the first thing you get is your nasal cannula, which has 2 areas. So we will be able to cut one side. So this is our nasal cannula. So you will cut one side and then you will elongate it using the intravenous giving set. So you will push one side into the giving set. Then you will strap to avoid air leaks. So that is the side you will be using the other end for putting into our water. And in this case, our bottle has a hole onto the escape where we will be dropping it straight. So in this one, we will drop it straight to 5 centimeters to give us that positive continuous pressure. Then we will strap it. Just to make it firm. Then we will put this bottle just below the patient. Then we connect this other cut end should be also tightly knotted to avoid air leaks. Then we connect it to our oxygen source, which is the concentrator. Then we will be putting it to our patient, and then we secure it with the strapping. Then we can now connect, and then we observe for air bubbles from your water bottle. So at this level, you are giving continuous positive airway pressure to our child. And in this way, you will be saving life of our children. Thank you.
Not forgetting, babies will require liters of oxygen at different rates. Neonates, we shall put at 2 liters. Infants, 3 to 4 liters. And older babies, we can put 5 to 10 liters. Thank you very much.
Okay, thank you so much, Team Busitema, for that demonstration. I was expecting some something else, but yeah, thank you for that. Those who are having network issues and they have not really listened on to the video, it's going to be shared so that all of us can actually make our personal CPAPs in our different facilities. Lisa, could you wrap that up, the demo?
Yeah, so in our setting, we don't have CPAP machines, so we often use the improvised CPAP machine. And essentially what is being done is it is taking kind of oxygen cannula tubing, connecting one end to the oxygen source, then extending down to kind of the nasal prongs that are divided, connected to elongate the tube, and then insert it into a water bottle. And kind of the tube extends 5 centimeters depth to generate a CPAP of about 5. And so it's a really nice low resource option to provide additional respiratory support with just kind of routine nasal cannula and an oxygen source or oxygen tank.
Okay, thank you so much. Just to note that bubble CPAP just to note that bubble CPAP may not really work in the adults because of the high oxygen demands and high pressure demands. We used to use it in pediatrics in my internship, but I tried it in the adults and it would not bubble. So I think you can also check on that.
True.
Thank you so much, Team Busitema, for that interesting demonstration. Let us have a comment from Dr. Doreen on the Q&A session. You're welcome.
Thank you, team. I'm just going to highlight some of the questions that have been raised in the Q&A. There have been many questions in regards to the use of antibiotics. And just to re-emphasize what Dr. Lisa was talking about, the difference in the use of antibiotics amongst the different age groups, in the newborns, in the infants, and then children above 5 years. And it's because at different ages, there are different organisms that cause pneumonia. The more common organisms that can cause pneumonia in a newborn are different from the organisms that are going to cause pneumonia in a child between 1 to 5, and also the organisms in a child above 5 years. That is why there is a difference in the antibiotics. But also there has to be rational use of the antibiotic. There has to be justification, as Doreen has said, for the use of the antibiotic. So always consult in case you're not sure what to do. There was a question in regards to bronchiolitis versus pneumonia. Bronchiolitis is usually a viral infection that targets children less than 2 years old. It mimics flu-like symptoms, and usually it affects the bronchioles, while pneumonia is going to affect the alveoli, which are deeper in the lungs. So bronchiolitis, one of the things that will be typical is the age group it targets, but also the flu-like symptoms. Usually it's self-limiting, which means the child will, as the immunity builds up, the child will get better. But also you can do supportive therapy. If the child needs to be nebulized, you can nebulize, and there's room for nebulized steroids in bronchiolitis vis-a-vis in pneumonia. Otherwise, there are questions about people are not comfortable with gentamicin. The assumption is that it will cause kidney failure. Yes, gentamicin is nephrotoxic, but there has to be rational drug use with these antibiotics. So you have to ensure that you prevent any kidney failure. So that means that you give the right dose of the gentamicin specific for the child's body weight, but also you ensure that the child is hydrated ensure that you give maintenance fluids for the child. Someone asked, how do we monitor fluids in a child? You have to rely on your clinical skills. You might not necessarily put in a catheter and monitor the urine output, but you can rely on the pampers, but also look at the skin tagger, look at the sunken eyes, look at the fontanelle of the child, see if the child is irritable, but I believe prevention is better than cure, so ensure that the child is hydrated, maintain the child on the fluids necessary for their kilogram per body weight. Someone was asking about giving oxygen and how many liters of oxygen we have to give, especially when we are using the CPAP. And again, like Doreen said, use of oxygen, you can start off low and then you titrate depending on the oxygen need of the child. You can go low and keep monitoring, see how the child improves, and you titrate, which means you start low, keep increasing. If you realize that the child needs more oxygen, keep monitoring until you get your required oxygen saturation that the child needs. And there you can monitor your child effectively. Someone asked about the CPAP. Dr. Lisa, there are so many questions about the CPAP. They want to know how often we change the water in the CPAP bottle, but also if we have to use tap water in the CPAP bottle, and also the ranges of the CPAP according to the ages. If there are a different range depending on the age group of the child, and also how long a child will spend on the CPAP before they are taken off the CPAP. So Dr. Lisa, you can answer those ones.
Sure. So I would, we would typically use the bottled water like as we're doing CPAPs. So I guess tap water would be an option, but if possible, you're going to buy the bottle of water to kind of make the CPAP. And so I would generally say use the bottled water. The recommendation is technically that you change the water in the CPAP once every 24 hours. So that would be ideal and should be monitoring the level of your tubing inside. For most patients, we started a CPAP of 5, so 5 centimeters of tube inside water. And that's a nice start, kind of average for what most children need. Usually takes about 1 to 2 liters of oxygen flow to generate the appropriate pressure. For older kids, it might be more like 2 to 4. So kind of infants, I think kind of 1 to 2. Outside of infants, like older than 1 year, they might need more like 2 to 4 liters of oxygen to generate kind of appropriate CPAP and bubbling. Was that all the questions? Sorry.
Dr. Lisa, there's a question on how long should the child spend on CPAP before they are taken off the CPAP?
So I would say that in cases of pneumonia, most kids don't end up staying on it very long, so 1 to 2 days, and then the antibiotics have generally gotten in there and relieved some of the symptoms. You're really just buying time for the antibiotics to get in there and clear the infection so the work of breathing is reduced. In the case of premature infants, that's going to be a little bit different because the etiology of their respiratory distress is different. And so they, premature infants will sometimes be on CPAP for more extended periods of time. And Sister Doreen can probably comment on that better than I can.
Yeah, thank you very much. So when they were talking about what to use, so depending on the setting, from a low resource setting, so we may not have the normal saline always to use. And sometimes if you use saline and you leave it for some time, you find it crystallizing around the bottle. So we use distilled water. If we don't have distilled water, we use tap water. But when we use tap water, we put in a cup of vinegar and then you change daily. That's what we do. Now, about how long will the child be on CPAP? Of course, once they review, they're going to look at the initial signs that the child had. Are we still having the distress? How is the baby saturating? Remember, initially we were in 80s. Are we above 90? Can we step down? You're not looking only at the SATs, but you're also looking at the clinical manifest. If there's increased work of breathing, so you may leave them on, and then you taper down on the oxygen, and you keep observing. So really, it is not specific that you're going to say this, but as they get better, usually you win them off slowly. I think that's what I can say.
Thank you so much for that elaborate discussion. Just something to add on. I have seen some questions. How deep should the tube go? How far? So there are a lot of questions on CPAP, how to use it, when to use it. So I think it was explained a little bit in the video. You must have an indication, a clinical indication. And usually for you to provide CPAP, you must be in, the patient would be benefiting from a positive pressure ventilation, because CPAP gives that continuous pressure ventilation, but it is more of a non-invasive kind of modality. So how deep it goes depends on how much your peak expiratory end pressure, the peak end expiratory pressure, what we call the PEEP, that is the pressure that is going to keep your alveoli patent. So in children, it usually ranges from, I think, 3 to 5, 2 to 5. So if, for example, your baby or your child has like increased work of breathing, and let's say you want to, that is the reason why you want to give positive pressure. You're going to start at, let's say, 5. And as the patient's breathing improves, you're going to reduce. So by reducing means you get the tube, push it in 5 centimeters deep, that will be 5 of your PEEP. So as the baby is improving, you keep pulling it out. So like the length of the tube that is in the water, you keep reducing it. That is how you reduce the PEEP. And that is determined on the patient response. I hope that answers that. Then there is someone who asked about oxygen concentrator. Oxygen concentrators come in different percentages in terms of the oxygen they can actually provide. I've seen those of 10, I've seen those of 20, I've seen those of 5. So it depends on your goal. If you have a if you have a concentrator that is going to release for you 5 liters of oxygen, and let's say there is a baby on let's say CPAP, you don't want to share maybe like 3 babies with CPAP, because it means you're going to be giving them deficient oxygen, or you may not actually see the bubbling that you're expecting. And then there's also a common mistake that is usually in most emergency settings, but also hospitals, where someone who is a baby who is requiring high levels of oxygen is put on the same Y connector with someone who requires like less. So I think that would be a bit of a mistake. So if a baby is on nasal prongs, it is better if they shared with nasal prongs. You'd be damaging the respiratory system, the nose and all that of the baby if you connect this baby on nasal prongs, and then you get one who requires CPAP, and then you connect them using one Y connector. It means this one who's receiving nasal prongs is going to get very high pressure in the nose. It will be drying up, and then it may cause some local injuries. Yeah, that is something I needed to add on. Thank you for the elaboration. I think unless there are other issues or there are other questions, I would like to maybe re-echo or recap maybe key take-home points. I'll probably call in Dr. Lisa, but let me start with Dr. Nantai, because she was the case presenter. What do you think the audience needs to take home during this session.
Thank you everyone for listening in, and thank you to the presenters for the wonderful presentation. So our take home, my take home today should be when dealing with a child with pneumonia, we have to the rate of the respiratory distress also gives you a go ahead, as also Sister Doreen said, the number of days when they'll be on the oxygen, that depends on the clinical judgment. And then also my take home was about from Dr. Lisa, how to prepare the CPAP. Thank you very much.
Thank you so much, Dr. Sherina. Dr. Lisa, the main presenter of pneumonia today, what do you think the participants should take note or should go with at home and probably implement so that we try and reduce on the mortality rate of these children?
So I would hope that the take home is that pneumonia is a really important problem to recognize. It can be a clinical diagnosis, so it does not require an investigation to make the diagnosis, but appropriate classification of pneumonia or severe pneumonia and then management is really important in helping to prevent mortality in these patients.
Okay, that was very brief. I expected a list, but thank you so much.
Nope.
We can have the online participants also tell us what they have learned from this session, so that we also get those comments in as Dr. Doreen gives us a take home.
My take home is that the management of pneumonia should be individualized on the child based on the child's age, underlying medical conditions, but also the clinical picture of the child. Do not treat child A the way you have treated child B, but treat child A because child A presents to you in a particular way. Thank you.
Thank you so much, Dr. Doreen. Sister Doreen, you know we have two Doreens in the house. Sister Doreen, what do you think the nurses on the group and also the medical team on the group should go with at home?
The nurses, I'll look at the time when you're working, you're overwhelmed, you have a lot to do, you want to give treatment, you want to be sure that everything is done, but we can't do everything. However, I would like our nurses out there to be empathetic. Be empathetic and please communicate. In my unit, we have a number of runaways, but we have come to realize that these runaways tend to occur when probably there are no health workers around, when the doctors have not done their rounds regularly, or when there are no nurses at that point, so people tend to escape. But if you are able to talk to these people, communicate well, befriend them, once they trust you, they may not run away immediately, or at least they will want to give you the benefit of doubt. So for me, I think one thing that we should take home as nurses, kindly be empathetic, even with the stress and the hustle and everything, try to be empathetic, put yourself in their shoes. And then there's something, I was trying to read the research, I think it was in KIU, in Ishaka. They said a part of the things that would maybe cause morbidity and mortality would be if we are not giving the treatment on time. So if we can recognize early and start antibiotics on time, I think that is important. Thank you very much.
Thank you so much, Sister Doreen. Please, there is registration going on. The echo team is going to share a link. Please keep registering for the CPD points. Unless there is any other question, I would like to thank all our team present here on the ground and also the online team. Thank you so much. We hope you have learned so much from this. Personally, I've learned a lot of things from here. Thank you so much to the expert team. And I hope we do better as we go home, especially in setting up the CPAP machine, since there has been a very good demonstration. Thank you so much. And let's continue with the post-test so that we can wrap this up. Thank you so much for your time. And let's have a closing prayer, still from Sherina.
Let's pray. In the name of the Father, and of the Son, and the Holy Spirit. Heavenly Father, we thank you for today. We thank you for that the session has been successful. We thank you for that you've blessed us with knowledge, you've blessed us with wisdom. Father, we pray for that you continue guiding us as we go on with patient care, and may you provide for us, and we pray for a healing hand upon all your patients. In Jesus' name I prayed and believed.
Amen. Thank you so much. Thank you for cooperating with me and allowing me to be the coordinator of this eco session. I declare this session closed. Have a good evening and God bless all of you.
God bless you too. Thanks very much for the presentation.